Oral chemotherapy smells like something the body already knows it doesn't want. Sharp and synthetic, faintly metallic beneath the sweetness of the coating. A smell that sits in the back of the throat like a word you're not sure you should say. Every morning on the surgical oncology ward at Whitmore Medical Center, I begin my shift by preparing the medication carts. And every morning that smell is the first fact of the day. Honest, specific, and completely indifferent to whoever is preparing the medications. My name is Sina Adeyemi. I have been a staff nurse on this floor for 9 months, and I have been treated for 9 months as a useful and interchangeable unit of nursing care. Not unkindly, not cruelly, but the way you treat furniture you've stopped seeing. The nurse manager has never once asked my name beyond what she read on the intake form. Then Commander Joel Reinhold, my patient in room 312, 14 days on this floor, stood in the corridor during the worst crisis this ward had seen in 6 years, called me Bulwark for the first time in 6 years, and told every person in it that she had saved 200 of his men alone. Let me take you back to the morning that happened. The surgical oncology floor is where patients recover from the surgery that follows the diagnosis that changed everything. The patients here are not in crisis in the way a trauma bay is in crisis. They are in the slower, more interior crisis of a person who has just been told that their body has been doing something without their knowledge or consent, and who is now in the aftermath of the intervention that was supposed to fix it. They need monitoring and medication and wound care and the specific human presence of someone who can sit with them in the particular fear that belongs to this floor without needing them to perform recovery for the observer's comfort. I was good at sitting with that fear. I had learned to do it in places where the fear was larger and louder, and the skill had translated. To the surgical oncology staff, a quiet shift meant a manageable shift. To me, quiet was the frequency at which I had learned to hear everything. The subtle shift in a patient's breathing pattern, the change in the quality of their stillness, the specific way a person lying in a hospital bed moves when they are in more pain than they are reporting. I was a commissioned officer in the Army Nurse Corps for 11 years. A 60th critical care nurse, deployed twice to combat support hospitals in Afghanistan, and once embedded with a SEAL team support element at a forward location in 2013 that I am permitted to describe only in general terms. At Bagram Airfield in November 2012, during my second CSH rotation, a coordinated rocket and mortar attack struck the base during a night when the senior physician on duty had been injured in the initial strike, and the surgical team was overwhelmed within the first 12 minutes. I was the senior nurse on duty. For 4 hours and 17 minutes, I ran the triage floor of a combat support hospital, managing incoming mass casualties with 2 junior medics and 1 physician who had a significant head wound and who I kept operational by positioning him for the specific tasks his injury permitted and managing everything else myself. 207 patients came through in those 4 hours. 194 survived to transfer. 13 did not. And I have made my accounting with each of those 13 in the way that you make accounting with things that cannot be undone and that you carry forward rather than putting down. My call sign during that deployment was Bulwark. It had been given to me by the SEAL element I had been attached to in 2013 after the support rotation, in the informal way of people who name what they observe. I had been the thing that stood between them and the outcomes they had trained to avoid, and they had named me accordingly. I had not used the call sign since my discharge in 2017. I had brought it with me the way I bring everything from that time. In the interior, held without display, available if needed. The person who managed the surgical oncology floor was Diana Ewan, nurse manager, 12 years in the role, a clinical administrator who had built the floor's routines into a machine of considerable efficiency. She was not unkind. She was not contemptuous. She was something more corrosive than either. She was indifferent in the specific way of a person who has decided, without examination, that the staff around her are interchangeable components of a system she has already optimized, and that any component requiring additional attention is a problem of fit rather than a problem of understanding. She had never asked my name, not in 9 months. She addressed me as the Float in the first weeks and as Adeyemi thereafter, my last name from the intake form, spoken as a filing category rather than an identity. She gave me the assignments that the permanent staff preferred not to take. She excluded me from the monthly clinical case reviews by scheduling them when I was rostered for the rooms furthest from the conference room, which I had initially interpreted as coincidence and had stopped interpreting as coincidence at month 3. She did not supervise me with hostility. She supervised me with the specific absence of attention that communicates, without words, that you are not considered worth watching. Commander Joel Reinhold had been in room 312 for 14 days when the floor changed. He was 51, retired SEAL Team commanding officer, admitted for post-surgical recovery following a partial colectomy related to a colon cancer diagnosis made the previous spring. He was recovering well. He was also the most attentive person in any room he occupied, which I recognized on his first day because it is a quality I share. The specific, trained attention of someone who has spent years in environments where missing a detail was not an inconvenience, but a casualty, and who cannot turn it off because it is no longer a behavior, but a structure. He had asked my name on his first day, not as small talk, as orientation. He had asked it the way you ask the name of the person responsible for your survival in a context where knowing that is relevant information. I had told him. He had used it. Every time thereafter. I noticed that he watched me during medications, during assessments, during the quiet passages of the shift when I moved between rooms with the economic attention I had been trained to maintain. I did not find it unnerving. I found it recognizable. The watch of a person cataloging competence. Building a picture through observation the way you build intelligence through accumulation. He was doing what he did. I was doing what I did. We had an understanding that required no articulation. The first confrontation with Diana Ewan happened at the nursing station on a Thursday, in front of the day shift, 7 weeks into my rotation. I had flagged in 3 consecutive shift reports that the patient in room 308, a 66-year-old woman, 5 days post-colectomy, was showing the early hemodynamic signature of an anastomotic leak. Subtle tachycardia trending up across 12 hours, a slightly elevated CRP I had requested be added to the morning labs, mild abdominal distension that was outside the expected post-surgical baseline. The attending had reviewed twice and determined the patient was within normal recovery parameters. I had documented my observations in detail because the record should exist even when the record is not acted on. Ewan called me to the nursing station. She had my shift reports in hand. She did not sit down. "You flagged the same patient 3 shifts in a row," she said. "The attending has reviewed and cleared her twice. I've had to pull the surgeon out of 2 separate procedures to come look at a patient who is, per her own physician, on a standard recovery trajectory." She set the reports on the counter. She did not raise her voice. She did not need to. She used the flat, procedural tone of someone for whom the conversation was already complete before it began. "I need you to understand that repetitive escalation without new clinical findings is not attentiveness. It is a workflow problem." She looked at me for a moment. The specific look of someone who has decided they have been clear enough. "I'm going to assign you to the med cart through the end of the week. We'll revisit your patient assignments after I've had a chance to review the flag pattern." I looked at the shift reports on the counter. I said, "Understood." I went to the medication cart. The medication cart is not a punishment in any formal sense. It is necessary, unglamorous, and requires the same attentiveness as any other nursing task. I worked it without complaint. I documented everything I was in a position to document. I watched room 308 from the cart when the cart was near enough to allow it. And I noted in my personal log that the patient's tachycardia had reached a rate of 102 at the 16-hour mark, and that her abdominal distension had increased, and that the attending had not been called again because the escalation pathway had been closed by the workflow review. The patient in room 308 went to emergency surgery for an anastomotic leak at 11:37 that evening. She survived. She was in the ICU for 4 days and returned to the floor on day 5 and went home on day 12. I was not on shift when she went to surgery. I had not been permitted to be on shift when it happened. Second escalation. 3 weeks after that, more quietly, more finally. UN restructured the team's clinical observation assignments. She did it through a scheduling change rather than a conversation. My name simply appeared on a different assignment list, managing the rooms furthest from the acute acuity patients. The rooms where the monitoring requirements were minimal and the clinical complexity was low. She did not explain the change. She did not need to explain it. In institutional terms, it was a scheduling decision, which is a thing that managers make and staff accept. I accepted it. I worked the low acuity rooms with the same attention I would have given the high acuity ones, because attention is not a function of assignment, and I had not learned to make it conditional. The morning the floor changed was an ordinary one. The medication cart, the chemotherapy smell, the particular quality of the surgical oncology ward at 7 in the morning when the shift is settling into its pace. 3 patients had come back from the OR the previous afternoon. Routine post-oncological surgical cases, same operating team, same anesthesia protocol. They were in rooms 314, 316, and 318, on the far end of my low acuity assignment. I was at the medication cart preparing the morning pass when the monitor in room 314 began an alarm that I had not expected. I went to 314. The patient, a 59-year-old man, day 1 post-prostatectomy, had a blood pressure of 83/51 and a heart rate of 127, and the specific pallor of someone whose vascular system was making urgent decisions. Internal hemorrhage, post-surgical. It was not ambiguous once I was in the room. I called the rapid response. I went to 3116. The patient in 316, a 63-year-old woman, day 1 post-bowel resection, had a blood pressure of 79/44. Same presentation, same timing. Related almost certainly to the surgical protocol from the same OR team the previous day. I did not wait for the rapid response team to arrive. I went to 318. The patient in 318, a 71-year-old man, day 1 post-hepatic resection, had a blood pressure of 88/52 and was semi-responsive. 3 patients in simultaneous hemorrhagic shock. Same floor, same time. No physician yet on the floor. What happened in the next 11 minutes was a mass casualty response on a surgical oncology ward. I know that phrase sounds wrong in that context. I know it sounds like an exaggeration. It is not an exaggeration. It is the accurate description of what I did. The specific cognitive and physical work of triaging multiple simultaneous critical patients without the resources to manage each one optimally and with the imperative to make the sequencing decisions that maximize survivability across the group. I had done this before. I knew the protocol in my body. I prioritized by survivability window. Room 318 first because his hepatic resection left the least margin, his pressure the most tenuous, his window the narrowest. I placed the IV access, initiated the fluid resuscitation, positioned him, called his pressure to the rapid response team arriving at the door, and handed him to them without stopping moving. Room 316. Next, IV access, fluid positioning, verbal handoff to the second responder, who arrived 30 seconds behind the first. Room 314. The patient who had alerted first was, paradoxically, the most stable of the three. His vascular response had been the loudest, but his pressure, when I rechecked it, had responded to the initial positioning protocol I had initiated when I came through his room the first time. The surgeon arrived. She assessed all three rooms in a sequence I had already organized and said to the rapid response team lead, loudly enough to be heard at the nurses' station, "Who ran this triage?" The team lead looked at me. "She did," he said. The surgeon looked at me. She had the expression of someone who has arrived expecting chaos and found it ordered, and is processing the gap. "What's your background?" she said. I was about to answer when I heard Commander Reinholdt's voice from the corridor. He had come out of room 312. He was in his hospital gown, post-surgical, still recovering, moving carefully, but moving with the specific purposefulness of someone who has decided that the purpose outweighs the discomfort. He was standing in the corridor outside room 318, and he had clearly been watching through the door, and he had the expression of someone who has been waiting to say something and has found the moment. "Her name," he said, to the surgeon, to the rapid response team, to the nurses clustered at the station, and to Diana Ewan, who had arrived from the far end of the corridor with the expression of a manager who has come to manage a situation she is currently unable to categorize, "is Captain Sena Adeyemi. She was Army Nurse Corps, 66H, 2 Afghanistan deployments. She ran the triage floor at Bagram during the November 2012 Mascal event. 207 incoming casualties. She managed it with 2 medics and a concussed physician." He paused, the pause of a man who has not rushed a sentence in 30 years of operational environments and was not about to start. 194 of those men were mine. She saved them alone. The corridor was very quiet. The monitors from rooms 314, 316, and 318 were doing their work, the numbers climbing, the patient stabilizing, the floor finding its way back to the side of the threshold it was supposed to be on. Diana Ewan was standing 12 feet away with my shift report still in her hand from the earlier conversation. And she was looking at Commander Reinholdt with the expression of a person who has built a professional conclusion on a foundation that has just been revised without her consent. Commander Reinholdt looked at me. He had the specific expression of a man who has been watching for 14 days and has finally said the thing he came to say, and who is now doing what people who have delivered important information always do, waiting to see how it lands. "Bulwark," he said. One word. The word that had been given to me in 2013 by people who had needed to name what they were depending on. The word I had carried without using for 6 years in this building and the ones before it. The way you carry anything that belongs to a context you are no longer inside. Not as a credential, not as a performance, but as a reference point. I looked at him. "Commander," I said. He straightened. He came to attention in the careful, deliberate way of a man for whom attention is not a physical movement, but a full-body statement. In a hospital gown, in a surgical oncology corridor, 14 days post-colectomy, coming to attention with the specific completeness of someone who has decided that the location is irrelevant and the statement is not. He raised his right hand. The salute was held. It was not perfect. His arm, still recovering, would not achieve the full angle of dress uniform precision. But it was complete in the way that matters, which is the intention rather than the geometry. I returned it. My right hand came up with 12 years of muscle memory and 6 years of not using it, and the two together produced something that was correct in both directions at once, The hand that had done this before, and the hand that had been waiting to do it again. And I held it for the full duration, and I brought it down. The rapid response team lead brought his hand up. The surgeon brought hers up. 2 of the staff nurses brought theirs up, uncertainly. Then with more certainty, the way people join something when they have understood what it is. Diana Ewan did not raise her hand. She stood at the end of the corridor with the shift reports in her hand and looked at something that her experience had not prepared a category for. That was all right. It did not need her category to be true. The 3 patients went to the ICU over the next 90 minutes. All 3 came back to the floor by day 4. The patient in room 318, the one I had gone to first, the one whose window had been the narrowest, sent a card to the ward 6 weeks after his discharge that said only, "I don't know who made the right call about me, but whoever it was, I am grateful." The card was pinned to the bulletin board at the nurses' station by the charge nurse, who did not know the full story and did not need to. Commander Reinhold was discharged on day 17. On the morning of his discharge, he called me to his room. He was dressed. He had the particular appearance of a man who has been somewhere difficult and is returning to the world with the measured deliberateness of someone who knows the value of both sides of that threshold. "You know what I noticed," he said, "in 14 days on this floor?" "You noticed a lot," I said. "I noticed," he said, "that you caught 3 things nobody else caught. Room 308, and the 2 patients in the middle of the night in week 1 who you flagged for the overnight resident and the medication interaction in room 301 that you sent to pharmacy without making a meeting about it." He paused. I kept a list. I looked at him. "Did you?" "Habit," he said. He held out his hand. Not in a salute. In the ordinary human gesture of one person acknowledging another across whatever distance exists between them. I took it. We shook hands with the specific quality of 2 people who have worked in environments where a handshake carries more than the ceremony of it. "Captain," he said. "Commander," I said. He left. I went back to the medication cart. I was midway through the morning pass when the crisis had started, and I was midway through the morning pass when the crisis was over, and the cart did not care about the interval. The patients needed their medications. The medications needed to be prepared. The work was the work. I crushed a tablet. I drew the suspension into the syringe. I noted the time. I moved to the next room. Still here, still counting. If Sina's story moved something in you, hit the like button and share this with someone who needs to hear it today. Subscribe to this channel. We tell the stories of the ones nobody looked at twice, until the moment when looking away was no longer possible. Drop a comment below and tell me what city you're watching from. I want to see how far this one reaches.